following is a production of West Virginia Public Broadcasting.
Major funding for Doctors on Call is provided by a grant from the Milan Charitable Foundation. Other funding is provided by the Health Plan, a health maintenance organization serving West Virginia and Ohio since 1979. By the Center for Organ Recovery and Education, supporting Volunteers for Life through organ, tissue, and corneal donation. By Health South Rehabilitation Hospital, serving your rehabilitation needs in Morgantown and Fairmont. And by the faculty and staff of the Robert C. Byrd Health Sciences Center of West Virginia University. Welcome to Doctors on Call. Tonight's topic, breast cancer. Two experts are here to answer your questions. Now here's your host, Dr. Raleigh Sullivan.
Good evening. We've all heard the statistics. 1 in 8 women will get breast cancer. Whether she survives depends on a number of factors, but among the most important is early detection and treatment. What are the latest recommendations for mammograms? Who should get chemotherapy and radiation therapy? Is surgery an option for you? We'll get answers to those questions and more tonight from our two guests, Dr. James Abraham, Director of the Comprehensive Breast Cancer Program at WVU's Mary Bab Randolph Cancer Center, and Dr. Hannah Hazard, a surgeon at WVU who specialized in breast cancer surgery. If you'd like to ask our guests a question, give us a call. Our phone lines are open now. So, James, let's start with you. What are the latest guidelines for women and mammograms?
For a person with average risk factor, the mammogram should start at the age of 40, and then after that, we should continue that every year. So now the screening is mainly done with mammograms. Let's just say somebody has a strong family history or any other risk factors, any risk for carrying an abnormal gene, any previous biopsies, so any other consideration, then probably you should talk to the family doctor or the primary care doctor and start early. But otherwise, it starts at the age of 40.
So for a routine, starting at age 40, and how often thereafter?
Once a year.
Once a year thereafter.
Right.
Okay. Let's get Hannah in this. Hannah, I know that some people, you're a surgeon obviously, and some people are kind of perfect candidates for surgery.
Sure. When a woman is diagnosed with breast cancer, we sit down and we talk about not only what the tumor looks like, but its size, and then also we talk about what the patient would want as far as surgical care. When we talk about breast cancer, there are generally speaking two main options for women to take out their tumor. One is a lumpectomy, which is where we remove the tumor. We get around it with negative margin, so getting the entire tumor out. And the other option is a mastectomy, where we remove the breast. Some women are really good candidates for a lumpectomy. Other women are not good candidates for a lumpectomy. And that's a discussion and a decision that takes place between the patient as well as our surgeon.
Would you mind, I know we're just kind of getting started, do you mind talking about how you sort of decide that?
Well, a lot of the factors, the first factor actually is what does the tumor look like, how large is it, and then not only how large is it, but what is that size in relationship to the size of the woman's breast. So a woman who has a very small breast with an average sized tumor probably isn't going to have a breast that is as cosmetically nice at the end of it versus someone who may have the same size tumor but in a larger breast. And so we weigh those factors in when we talk about what would be the best surgical option for that patient. And that comes from our knowledge that as long as we get around the tumor, we get it out, and then we add in radiation with lumpectomy, then those women have the same survival as if we did the mastectomy. What becomes really important is not only the cancer, which is obviously our main goal, but the other thing is cosmetically at the end of the day, how is that going to look? Is it something that the woman's going to wish that she had preserved, or is it maybe the better part of valor is to go ahead and remove the breast and then possibly begin the reconstructive process?
Yeah, I'm sure that's a very tense an important discussion.
The other factor that not only is the tumor characteristics and its size, but also the patient wishes. So when we sit down and we see these are the risks and benefits with each one of these types of surgical procedures, oftentimes I bring it back to them and say, okay, what are you the most comfortable with? Here are the statistics, here are your options, but emotionally, where's your comfort level lie in all of this? And so it acts as a way of having the patient then begin to participate again and make some choices in a situation where they feel like they really sort of have no choice and that everything's sort of spinning out of control.
Let's talk about predictive factors. Who is at risk to get breast cancer? You want to ask that, James?
Sure. So there are multiple things play in that. Age of the person is really important. And as we heard, 1 in 8 person in North America can potentially get breast cancer. So older the age, the risk for breast cancer.
Older?
Yes. Yeah. Older the age, the risk for breast cancer goes up. The average age of diagnosis is about 62 or 63. Then strong family history, that's an important consideration, especially first-degree relatives, and I mean sister or mother. Then any history of ovarian cancer in the family, then we start talking about an abnormal gene. That again increases the risk substantially. And of course, if there's, even from the paternal side, father's side, if there is multiple family members with breast cancer at an early age, that increases the risk. Then the menstrual history is important. If they have an early period, an early menarche, that increases the risk for
starting their periods early in life?
That's right. I mean, that's one of the hypotheses, one of the theory why the incidence of breast cancer has been increasing, probably in a sedentary lifestyle, and that kind of increases, or that kind of predisposes girls for an early period. So our lifestyle play a major role in breast cancer too.
Lifestyle, we'll talk about that in a minute. Lifestyle plays a role.
So lifestyle, a couple of things which are proven in large studies are, one, exercise.
Okay.
Exercise can clearly decrease the incidence of breast cancer. Diet plays a major role. Low-fat diet can decrease the incidence of breast cancer. I mean, alcohol studies are kind of controversial. Some studies say it increases, some studies it's protective. So, but clearly diet and exercise.
So what were you saying, low-fat diet?
Can decrease the incidence
can
of breast
decrease the incidence of breast cancer. Low-fat diet, well, that's interesting. I'm learning things all the time on this show. We have our first caller. This is Karen from Lawrence County, Kentucky. Karen, welcome to Doctors on Call. You have a question for us?
Yes. I have a history of cancer on my mother's side of the family. She had 2 sisters with breast cancer and ovarian cancer. She had 2 brothers with prostate cancer, and one of their daughters had ovarian cancer. I just recently been told that I had a mass in my left breast. I had a technician to give me a very thorough breast exam. The mammogram didn't show nothing, but she ordered an ultrasound, and the ultrasound shows that I do have a mass in my left breast. And the radiologist is saying that it's probably benign, but they're wanting me to wait 6 months for another ultrasound. What my question is what kind of a percentage do you think with the cancer on my side of the family, what do you think is it probably being benign? I have a lot of pain.
Okay.
I'll hush now and I'll let you talk.
Okay. She has pain, a strong family history, and
so I'll take the first part of the question, Karen, and then I'm sure Dr. Hannah can explain, tell you more about the mass side. So I'm glad you're asking this question. Actually, you have a very strong family history of breast cancer, from both sides of the family, and history of ovarian cancer. So people like Karen, and those are the patients whom we talk about a potential risk for an abnormal gene. So about 5 to 10% of patients may carry an abnormal gene, especially when we hear a very strong family history of breast cancer and ovarian cancer. There are two genes, what we call as BRCA1 and BRCA2. It's a blood test. With a blood test, we can see if that person carries that gene or not. So what can, I'm talking from your risk side, probably you should talk to your family members with the history of breast cancer and see if they were ever told about this gene and if they had any testing done. That's the first thing probably we should consider. Second, if they haven't done, probably they should be talking to their doctors about the testing. And if you would like, you can talk to your local surgeon or your family doctor about your specific risk. And then he can actually calculate your risk and talk more about your gene testing. As I said, it's a blood testing. I'm sure Hannah can talk more about the mass and the pain.
So women who present for their screening mammogram generally get two standard views, and what Karen is talking about is a lot of women will have things that we can see on mammogram but we can't necessarily see on ultrasound and vice versa. By not seeing something on mammogram, the perfect workup has already happened, and that is to proceed on with an ultrasound. When we look at ultrasounds, we can see a variety of different things by ultrasound. We certainly can see masses. Some of those masses have characteristics that clearly make us worried that there may be a cancer sitting in there. And those masses tend to have pretty definitive characteristics. There are other things that you can see on ultrasound that are less characteristic of cancers. So cysts are very characteristically seen on ultrasound. Some of those can be very benign looking. Other things like fibroadenomas or other sort of similar lesions you can see that don't have those very concerning characteristics by ultrasound. Oftentimes when we do radiographic imaging of the breast, mammograms, ultrasounds, we have a standardized way of sort of grading them. Things that clearly look like cancer move on to biopsy. Things that clearly look benign, sometimes we will watch at yearly intervals. And then those that are somewhat in between, we like to look at it 6 months. And so I think combining, most radiologists and most of us tend, particularly with strong family histories, we tend to be a little bit more aggressive or with imaging findings. So if the ultrasound looks like it's benign and they recommend a 6-month follow-up, my guess is that there are some features on that ultrasound that are clearly don't look like a cancer. However, you should always talk to your family doctor, put those two pieces of the puzzle together.
So it sounds like she's getting reasonable advice and treatment
like
at this point.
Yep.
We have another caller. This is Matt from Gallia County, Ohio. Matt, welcome to Doctors on Call. You have a question for us?
Yeah, I have three small tumors. Barbara, turn it off. I have 3 small tumors underneath my left breast, and they just came there this last 6 months or so.
And what's your question?
What should I have done to see about it?
Okay.
So you bring up a very good point by your call. We always think of breast cancer as only being a disease of women or something that women are diagnosed. And in fact, about 1,000 or 1,100 men are diagnosed with breast cancer each year. When men detect a mass or a lump in their breast, they should go and see their primary care physician to allow them to do a breast exam. Even though men don't think it's possible, mammograms are possible in a man. And in addition, ultrasounds are also possible. And so men don't generally come in with that complaint, but when they do have that problem, then being evaluated by your primary care doctor and having a physical examination and then proceeding on with mammogram ultrasound as deemed appropriate is very important.
That seems reasonable. Let me, at this point, if you would, and maybe Hannah, you could do this, talk about what a self-examination would be like for a woman regarding breast cancer.
So a self-breast examination is something that a woman should do consistently about once a month. Usually you do it at the same time every month. For women who are premenopausal and still having periods, usually doing that sometime outside of your menstrual cycle is really sort of important, and consistently a week after your menstrual cycle, a week before, but just some consistency. You want to cover the entire breast when you're doing an exam. You first want to inspect yourself in the mirror without your clothes on. You want to make sure that you don't see any skin changes, any red areas, any changes to the nipple itself. You also want to make sure that you don't see any dimpling or sort of a tethering, like there may be something there that's sort of pulling down on the skin. So you want to look for those kinds of findings. And then in just sort of a consistent fashion, you want to cover the entire area of the breast. You want to use basically the palms of your finger just in a flat way. And you want to cover basically from your collarbone all the way down to where your bra hits at the beneath the breast, and then out towards your breastbone, and then out underneath your arm. And you just want to cover that entire area. And you usually want to do that while you're laying down with your opposite hand, with the hand that you're examining up over your head. And so that becomes really important. At the end of the examination, I know the little cards that you hang in your mirror and in your shower always say to examine the nipple and squeeze the nipple. I don't personally recommend doing that, but you just want to be consistent about your examination.
And you recommend doing it monthly, getting in the routine for doing it
routinely monthly. A lot of times it's difficult to remember the week after your period, so I often tell women, remember whatever day your birthday is. So for me, it's the 9th, so on the 9th of every month, or for whatever your day, helps to sort of jog your memory.
Okay, great. We have another caller. This is Linda from Monongalia County. Linda, welcome to the show. You have a question for us?
I do. I'm 40 years old, and I don't have any health insurance. And I was wondering if you could direct me on how to obtain a mammogram.
So at this point, the state has a program which is actually the BCCSP program, or breast cancer and cervical cancer screening program. That if there is any suspicious lesion, and if you're worried about breast cancer, potentially the state will provide, or the different grants which will provide funding for a mammogram. So that's one way of doing it. And I know you are from Mount County, potentially Health Right or some of the clinics can provide these services. And there are offices of BCCSP program in Mount County.
So not having health insurance is not a reason to not seek treatment.
Right, but she's actually bringing up an important issue, and lack of access to care. It's actually that's as bad as an advanced stage cancer. So it's an extremely important issue she's bringing up. And I'm glad she's thinking about mammogram at this stage. As we talked before, early detection and mammogram clearly decreases the chance of a person dying from breast cancer.
Yeah.
So.
Okay, well, I think that's good advice. We have another caller. This is Cheryl from Fayette County. Cheryl, welcome to the show. You have a question for us?
Yes, I do. I felt a lump a couple of years ago and came to Ruby Memorial and received the mammatome biopsy, and the pathology reported that it was a papilloma. And I just wonder what the statistics may be for a papilloma to turn to breast cancer once diagnosed as benign.
Okay.
So you bring up a very important point. We have a lot of types of pathology or in the breast itself that are not clearly malignant and have a very low risk of becoming or being associated with a breast cancer. One of those is a papilloma, and a papilloma is a growth within the duct itself. Our breasts are composed of quite a few things, but importantly, the duct system is what basically allows our secretions, and when you're nursing, allows the milk to travel from where it's being produced out to the child. And an abnormal growth within that duct, like a papilloma, is not a malignant lesion and carries a relatively low risk of any future cancer.
So do you follow those?
Usually what happens with a mammatome biopsy is once we get a benign diagnosis, we always follow that up with a mammogram about 6 months later. And the interest is to look at the area that's been biopsied to make sure that what caused the initial biopsy to happen has not returned, or something else is not in that area that would warrant additional evaluation. And after that 6-month interval mammogram, then women go back usually to their screening mammograms.
Let me ask, when do you decide a biopsy is necessary? I mean, at what point?
So the things what we talked, Hannah was talking about, let's just say a person do a self-breast examination and feel a new lump, and that's clearly was not present before, and now it's there, or the lump, or there was an existing area which is changing. So that's the way, or there is some nipple discharge or skin changes. So those are the things the patient come to the doctor. That's one. Second, let's just say the patient is undergoing a screening mammogram. And the mammogram is picking up some abnormality. It could be what we call as a calcification, some new calcium deposits, which looks funny. Or it could be a mass. We're kind of saying, again, opacity in the mammogram. So those are the two major ways that we decide about doing a biopsy.
Okay. Let me ask you, because I'm kind of curious, if you make the diagnosis, well, first of all, there are different kinds of breast cancers.
Right.
Maybe you can talk a little bit about that. We haven't really gotten to that yet.
So let's just say most of the breast cancers are what we call as ductal. So in the breast, we have a duct where the milk is produced, a lobule where the milk is produced, and through the duct it comes to the nipple. So most of the breast cancer, almost 80% of the breast cancer arises from the duct. And then we have something in the lobule in the back. So when people say breast cancer, most of the time it's the ductal type. And then it kind of comes out of the duct, and that's what we call as the invasive ductal. So, then there are different other types of ductal, what we call as inflammatory breast cancer. It kind of, sometimes the patients will come and say, I had this redness of the skin for the last 3 weeks, and I got antibiotics, it didn't get better. Then eventually the patient will get a biopsy, and that turned out to be malignant. That's so-called inflammatory breast cancer. So ductal, lobular, inflammatory, those are kind of the major ones.
Okay. Talk a little bit, if you would, and I guess, Jane, this might be better for you, a little bit about what treatment is like nowadays with chemotherapy and that sort of thing.
So chemotherapy has come a long way. As we were saying before, now less people are dying from breast cancer. Actually, more people live after the diagnosis or live with the diagnosis of breast cancer than people die from breast cancer. That's due to probably 2 or 3 major things. One, early detection. Okay. Second, effective treatment. When I say effective treatment, that's both surgery, radiation, and so-called systemic treatment or chemotherapy. So chemotherapy is medicines given through the vein. That's the mainstay of treatment. And after that, there are 2 other types. Then we put the patients on a pill, tamoxifen or one of those pills, for about 5 years or longer. And some patients actually getting another medicine known as Herceptin, which is a very targeted treatment for breast cancer, which is not a typical chemotherapy. So there are many different types of chemotherapy or medications available for patients now.
This may be a little bit of a Neanderthal question on my part, but do most women get both a combination of both surgery and chemotherapy?
So yes. So part of when we talk about treating breast cancer, we have to talk about not only treating the breast itself, which is your surgical treatment, removing the cancer, looking at the lymph nodes when it's an invasive cancer to get an adequate stage, so we know what stage the woman is. And then once they've completed their surgical therapy, then we also need to address their systemic therapy. So not only do we treat the breast itself locally, but we also have to treat the whole body. And so not every woman will get chemotherapy, but every woman, by and large, will get systemic therapy in some manner. Whether or not it ends up being a combination of chemotherapy and the pill, just the pill or just chemotherapy, that is really dependent upon the patient's disease that she's been diagnosed with and her stage.
We have less than a minute. What message would you like to get to women out there?
Continue with their screening mammograms and make sure they do the self-breast examination. And then there is hope, and more people live with the diagnosis of breast cancer or any type of cancer.
It's important. More people are living. I remember when it was so deadly, you know.
It's the most phenomenal network of women who are survivors because there are so many women living with the diagnosis and have conquered the diagnosis of breast cancer. It is a phenomenal network of women who have overcome this and wish not only to support each other, but also to support those that have recently been diagnosed. So it's a phenomenal community of women.
Yeah, it's been amazing. I appreciate this. Well, good evening. I think at this point, what we need to do, we've been talking about breast cancer with Dr. James Abraham and Dr. Hannah Hazard. Thank you both for being with us. If you'd like more information, see your family doctor or visit our website at wvhealth.com. For Doctors on Call, I'm Dr. Raleigh Sullivan. Good night and good health.
Join us again next week for another edition of Doctors on Call. Major funding for Doctors on Call is provided by a grant from the Milan Charitable Foundation. Other funding is provided by the Health Plan, a health maintenance organization serving West Virginia and Ohio since 1979. By the Center for Organ Recovery and Education, supporting Volunteers for Life through organ, tissue, and corneal donation. By Health South Rehabilitation Hospital, serving your rehabilitation needs in Morgantown and Fairmont. And by the faculty and staff of the Robert C. Byrd Health Sciences Center of West Virginia University.
This has been a production of West Virginia Public Broadcasting.